Good morning, everyone. Today I am here to speak on a topic which is a very critical topic for hepatology, pediatric hepatology, transplant, and the hematology team. So, it is prediction of response to plasma exchange in acute liver failure, a topic on which there is absolutely zero literature as of today. Now, there are several studies, RCTs, meta-analysis, propensity match studies in children, and the guidelines now recommend plasma exchange for acute liver failure. But none of these studies address how exactly do we monitor once we start the patients on plasma exchange. So what we all know that TP plays haywire with the biochemical parameters. The exact biochemical parameters like INR, bilirubin, ammonia, everything comes down as soon as you do plasma exchange. Now, is that the effect of the endogenous clearance by the plasma exchange, replacement of the donor recipient plasma with the donor plasma, or actual improvement in the biochemical trajectory of the hepatic recovery? That we cannot say. And these parameters are very critical because they are part of any and every prognostic score. INR is part of all prognostic scores, whether it is KCH, PEDS HIV, which we use in hepatitis A, or any other model. So the trend of conventional lab parameters that we follow, that there should be improvement in INR, there should be improvement in bilirubin, all that stuff, ammonia, that is not accurately reflected in these patients who are undergoing plasma exchange, as this can be just done by due to the effect of replacing the plasma, and this is further compounded due to repeated sessions. Woods and Jacobs way back in 1986 had shown that any substance which is present in the plasma, when you do a plasma exchange, whether it is plasma proteins, whether it is toxins, whether it is cytokines, will be reduced by 60 to 80% depending on the volume of plasma that you exchange. Then there will be a gradual rebound due to reaccumulation. Then if you do the second exchange, it will further go down and then it will rebound. So there is a cycling process where there will be fall and rebound, and we usually tend to do up to 3 plasma exchange. So this is very difficult to predict. One way which I think, which is not described as such, but one way which I think is what we can do is we can maybe check these peaks. If these peaks are going down, that may be an indirect indicator that the patient is improving. And if these troughs are also going down, that is also an indicator that the patient may be improving. What would happen in non-responder? If you do a plasma exchange, everything will go down, but it will accumulate very rapidly. Again, it will go down with the second plasma exchange, again it will accumulate. So anything which is rebounding back, the peaks are not going down, may be a indicator of non-response to plasma exchange and need for liver transplantation. So let's go with a case. A day-to-day run-of-the-mill case that we get in ILBS. A 13-year-old female, hepatitis A related ALF, jaundice to HE interval of only 3 days, HE grade 3, so intubated, INR was 4.24, ammonia was 396, bilirubin was 16.5. This is a classical patient who will never meet a KCH criteria but is actually very sick. So we use PEDS HIV criteria 2/3 listed for transplant, and donor evaluation started. First plasma exchange done, INR immediately post plasma exchange was 1.9, which rebounded to 3.1. Ammonia was 301 and 168. A donor has become ready at this time point. What would the audience think? What would you do? Would you proceed with LT at this time point? Would you want to differ by doing another plasma exchange? Or would you not do anything? Actually not do a plasma exchange and wait and watch the INR trend. What would you do? Those who say that proceed for LT right away. Okay, a few of them. Those who say that do another plasma exchange and watch there is some response. Okay, there are a few. And those who say that no, don't do any further plasma exchange, just wait and watch the INR. Okay, so we have people raising hands in all, and that is what is actually happening. There is so much of conflicting opinion, there is so much of subjectivity that ultimately a decision cannot be made. And many people did not raise their hand, which I would assume they are too confused to actually raise hand in anything. So let's go forward and see what happened later. We did a second plasma exchange. That was what was decided after a lot of deliberation. Again, the INR went down, rebounded again to 2.8. Now, this was the time point we started feeling maybe the patient is not responding ammonia. Anyways, we went ahead and did the third plasma exchange, following which you can see that the INR rebounded only up to 1.7, and thereafter it gradually reduced to 1.5 and thereafter. So by day 5, everyone is clear. Now, this time point, I think all of us can say that this patient needs nothing. But problem is taking decision here. On day 2, day 3, day 4, that is when the decision making is critical, and there is absolutely nothing in literature to guide you how to take these decisions. So if I was asked the question how to dynamically predict the response to plasma exchange early on day 2 or day 3, I would put it is like this, that the markers of inflammation should be going down. So the markers of inflammation should be going down, that is the pro-inflammatory cytokine should be going down, anti-inflammatory cytokine should be going up, microRNA signatures, organ failures and acidosis may also give a guide that markers of inflammation are going down or not. Then some studies have shown that regenerative markers, some studies have shown that rising AFP may be a good marker. But in our practice, we have not found this to be useful. Some have shown decreasing serum phosphate, which is actually a good guide, but we don't know the cutoffs, we don't know the levels, how do they change. Some have studied more than 25% fall in wall midebranch fracture as a predictor of response, improved hemodynamics and monocyte phagocytic function. Now these are actually difficult to do in a daily clinical practice. Day 2 you don't get. The turnaround time with inflammatory cytokines is quite long, and even with the growth factors it's quite long that you can actually take a clinical decision while the patient is with you. So ultimately we get guided by trends in biochemistries, HE trend, organ failures and prognostic scores, and which becomes very subjective. As we just saw, the opinion of the house was completely divided, almost 1/3, 1/3, 1/3, and many were unsure of where to raise their hands. So there are a few studies, like Dr. Anupam has done this study with us in pediatric acute liver failure, where he has shown that he can predict based on the spare reserve capacity where not to do plasma exchange. But then that is a question for another day. Today we are talking about response. So then Dr. Rakhi's study has shown that pro-inflammatory markers will decrease, anti-inflammatory markers will rise, growth factors although decrease but doesn't affect the outcome. But again, the responders versus non-responders were not compared, and this was day 0 to day 5 comparison, and we need day 1, day 2, and how does it affect. So how do we predict response to TP? The question is again back to square one. Once the TP sessions have started, in an objective manner, in a reasonably quick time when the patient is with you and the donor is ready, LT is ready, preferably bedside. And to answer all these three, can ML models provide early objective prediction? So to answer this question, we did this study. Now this is our ML workflow, and to be fair, this was done by my colleague from IIT, so I may not be able to answer intricate questions about this, but I have a fair idea and I may be able to answer that. And this is something like, this is my colleague whom I met while playing badminton in Siri Fort. So our famous tagline goes for CCD, like a lot can happen over a cup of coffee. So I think a lot of collaborations can happen over a game of badminton as well, if you are aware and open with your eyes and mind. So we use the Python kit here with grid search CV. Data pre-processing was done as is the routine ML workflow with 30 random permutations after dividing the cohort into training and validation set, and multiple 30 iterations were done because the sample size was low. Augmentation was applied only to the training data set. Hyperparameter tuning is kind of you tune your model to optimize your, like optimizing your settings, like you optimize your settings of guitar before playing it. So it is something like that. You tune the model so that it has the best predictive efficacy once it starts learning from the training data set. Now feature selection is the most critical step, though it was done in 2 steps. One was the preliminary selection done via clinical expertise was done by us, and then the final selection was done using RFECV, which is a technique, recursive feature elimination by cross-validation, done using LR as the base estimator and using other models as well. So the final models deployed were all these 5: random forest, logistic regression, gradient boost trees, XGBoost, which is a kind of tree model but advanced, and support vector machine. And after evaluating the models, the best 3 models, that is the logistic regression, XGBoost and SVM, were incorporated into a web-based tool. So out of the patients, till now we have had 510 patients, but we have started doing plasma exchange only after 2017. So only 134 patients, and we do in very selected patients with great, with advanced, where we feel the outcomes are not going to be good. So we did plasma exchange in 134 patients. those undergoing LT have been excluded because the outcome cannot be this way or that way. So ideally, I considered them among the non-responders, but this was what was decided when we planned the study. So the responders here are those who survived with their native liver, and non-responders are those who died. So we have only two parts, 51 and 59 out of 110 patients. And these patients were mainly hepatitis A, more than half of them, and 1/4 of them were indeterminate ALF. I'll spend a minute here to describe the time points, because that if you there has to be some clarity on these time points that we have used. So when we do 3 plasma exchange, suppose TP 1, 2 and 3, we label any, what we used was, we saw that we were anyways doing repeated tests, INR, ammonia, bilirubin. So we thought we'll use those tests because we have those tests in our HIS, but it was not done in a protocolized way when it was started in 2017 up to almost 2024. There was no set protocol when do you do the test. So what we decided was, anything from ending of first plasma exchange to first 6 hours will be counted as T1. Similarly, T3 for that after second plasma exchange, and T5 for first 6 hours after third plasma exchange. What I'd like to point out more emphasize would be that T2 time point, this is a critical time point, that is around 12 to 18 hours away from the first plasma exchange, that is just before the second plasma exchange. T4 is 12 to 18 hours after second plasma exchange, just before the third plasma exchange, and T6 is 12 to 18 hours after third plasma exchange. So these biochemical parameters at T2, T4, T6 are done at least 12 hours away from the last plasma exchange which was done. So this is the baseline cohort of 110 patients. Most had grade 3-4 HE right at admission. Others progressed, or some did not progress to grade 3 to 4 HE, although they may have had high INR. And final 66%. Since 2021, we have started using CRRT in all patients with hyperammonemia and advanced hepatic encephalopathy. So 66% also received concomitant CRRT. Survival with native liver I have shown 46%, and death was 53.6% in the cohort. Now coming to the feature selection, this is the important guide, like what features were actually used to determine the response, or to finally used in the model. So you can see that at point T0, 8 variables, at point T2, 6 variables, and at point T4, 9 variables were used. The variables marked in blue are dynamic variables which change over time, like INR, ammonia, it keeps changing. INR T2, ammonia T2, INR T2, T4 and so on. And variables marked in black are constant variables which also affect the outcome. Now HE grade has been marked as a constant variable because most of our patients were HE grade 3. Until we find the improvement in the INR, we don't start weaning or wake up the patient. So we cannot assess the dynamic change in HE. So HE has been marked as a static grade right at the time of admission. This is the feature importance ranking which we can skip. Hyperparameter tuning we can skip. This is basically to improve the model, tune the model just prior to we start training the model, we do this. So let's first verify whether what we had seen, that Woods and Jacobs, that thing, whether it actually happens. So if you see the trend in INR, you can clearly see that the INR, the blue is the non-responders, the orange is the responders. You can see that the responders INR starts at lower, goes lower, but doesn't rebound after T2. This is something important. Second important thing to see is if you do a test at T1, you cannot differentiate between responders and non-responders. They will have similar, because you have done plasma exchange, INR will be same, ammonia will be same, bilirubin will be same. You cannot get any idea with those tests. Where is it important? At T2, where the non-responders start showing rebound, whereas responders shows a bit of rebound but not as much as the non-responders. Similar things happen at T4 and T6, and T1, T3, T5 are not good times to do the test. So what this slide tells us is we should standardize the testing protocol of patients on plasma exchange in such a way that we do these biochemical parameters at least 12 to 18 hours post the last plasma exchange, where it can help us differentiate between and decide whether the patient is responding to our plasma exchange or not. Coming to the ammonia part, I skipped the bilirubin part because bilirubin, yes, there was a difference between responders and non-responders, but there was a lot of overlap, which we know because our patients were mainly hepatitis A. So even a lot of patients who are improving with hepatitis A will actually have rising bilirubin because they go into a kind of cholestatic phase. So bilirubin may keep on rising even when they are getting out of their ALF, which is a very normal and routinely observed phenomenon. described phenomenon. Now coming to ammonia, you can see that there's a good differentiation between the non-responders who are higher and the responders who are at a lower level. Now, but issue here was 66% of patients were also receiving CRRT, and we know that CRRT clears smaller substances like ammonia much better than plasma exchange. So, if we include ammonia, trend of ammonia in our model, was it the effect of CRRT which we are studying and not the response to TP? That was a question for which we had, but somehow that question would get answered because our model included use of CRRT, except at one time point at which T4, at T4 we made a forced inclusion of CRRT into the model to account for the changes in ammonia. So, these are the training set. Once we developed the model, once we decided these parameters, we selected the features, we put it for training on the training set, and we found that almost all the 5 models that we are evaluating did reasonably well with scores more than 80%, with more than 80% accuracy. And thereafter, we tested them separately on the validation part, and for the validation part we found that 3 models, that is logistic regression, XGBoost and support vector machine, were consistently showing good AUC for differentiation of non-responders to responders. What is important to note here is the specificity of the model is modest. This is partly intentional because we don't want a lot of, or we don't want a significant number of false positives, because we don't want any patient to miss out on the opportunity for liver transplant if the patient has slightest chance of not responding to plasma exchange. So, the model is tuned in such a way that it is slightly bent towards, whenever there is a doubt, it would bend towards the decision of liver transplant, that is decision of non-response. So, that has been tuned that way. That is why the specificity is low, but sensitivity and positive predictive value is fine, and AUC at T4 is lower. As you can see, it is only 70 to 75%. This is partly because some patients did not receive a complete set of plasma exchange, and that is why the numbers at T4 were less, and the testing protocol also had some missing data which led to these smaller numbers, which could be the reason for lower AUC at T4. This is just the diagrammatic representation which showed the same thing, that LR, XGBoost and SVM were the best performing models. So, now we deployed this model onto the web based tool which has been hosted as of now on OnRender, but this is the most important part, because whatever you do, you can be a keyboard warrior and do all kind of predictive analysis for your entertainment. This will all remain an entertainment until you actually put it into clinical practice, or actually evaluate it in clinical practice. So, this was done to address the gap between the predictive analysis and the bedside utility. So, we use the input parameters. I will be just showing you right now that we use the very readily available parameters like INR, ammonia, all of us have those parameters, etiology, HE grade, JE interval, age, ALT, and use of CRRT. And we use the 3 best models. So, let me just quickly show you the model how it works. So, like suppose we have a patient, these are the real patients which I had just noted the UHID and the data. So, I have entered one of these patient data. That patient has received, it asks for how many plasma exchange. So, patient has received 2 plasma exchange. So, it opens up the other values. So, age, grade of hepatic encephalopathy, etiology, whether concomitant CRRT is being ongoing or not, jaundice to HE interval, ALT, and then if you enter 2, it opens 2 like baseline parameters after 12 to 18 hours after first plasma exchange, that is T2 parameters, and 12 to 18 hours after second plasma exchange. If you enter 3, there will be another line. If you enter 1, there will be 1 line less, and then you click on analyze, and it gives the prediction of mortality. What does prediction of non-response actually, prediction of mortality actually. So, using the 3 models which are the best models, performing models. So, in this patient it says that although we may feel that yes, this patient started with an INR of 4.7, it decreased to 2 and it was only 2.3 after second plasma exchange, we may feel that this patient is maybe going to improve, but actually what the parameter, the model tells us is that the risk of mortality is 73%, 77% and 89% by the 3 models respectively. This patient ultimately succumbed to his illness. Let me show you another example, as I have I think 5 minutes more. So this patient underwent one plasma exchange, 15-year-old, grade 3 HE, almost same. Etiology was hepatitis A. Etiology is important because we have clearly shown that hepatitis A, even our paper, even Dr. Rakhi's paper has shown that hepatitis A may plasma exchange works much better. Wilson disease, it works much better. So etiology was important. Jaundice to HE interval. ALT was 3100. Sorry, 3100. INR was 4.3, almost same. 4.7 the previous patient was. 4.3. Ammonia almost again very similar. Started with the ammonia of 433. Previous patient started with 493. The INR after 18 hours of first plasma exchange was 1.8 and the ammonia was 271. Again almost very similar, but INR was significantly better, ammonia was slightly better. Now you see the analysis in this patient, and it shows that so there is some, I think, issues with this right now. Maybe I have entered something wrongly, but it showed that this patient was showing low risk of mortality. Similarly, if I enter the data for that patient, maybe I have to just click it again. Yeah. So if I enter the data for the patient I described in the initial period, after the first plasma exchange, we are getting mortality of around 25, 30 or 30% using the tool. I'll just put the patient which I described initially. So first plasma exchange, this was when I asked you guys to give your opinion. 13-year-old with grade 3 HE, that was the finding in that patient. Hepatitis A, CRRT yes, jaundice to NC interval was 3 days, baseline ALT was 1800, then INR was 4.24 if you remember the case I showed, and ammonia was 396. INR had rebounded up to 3.1 and ammonia had rebounded to. The data when I asked you, and there was divided opinions, even in our team there was a lot of divided opinions, but if you see that this was saying that the risk of mortality was between 25 to 35%. So this is how it can supplement your decision making. Obviously it cannot replace the clinician in decision making, but it can supplement your decision making as of now. So what are the strength of this tool? Now first thing is, it is an objective parameter. What we decide, my feeling may be different, your feeling may be completely different, and none of us may be wrong. But this is an objective parameter. This is the first tool, whether in adults or in pediatric, to assess the treatment response when the patient is on plasma exchange. We deliberately evaluated multiple ML classifiers because each ML classifier has its own strength and limitations. So we can we can cover one's limitation with the other model's strength. It uses very simple, readily available parameters like INR you are anyways doing, bilirubin you are anyways doing, ammonia you are anyways doing. So easily available parameters. There was high concordance among ML classifiers, which increases our confidence, and when there is no concordance between ML classifiers, these situations also happen, are very difficult to actually decide. We use stringent feature selection, balanced CV, controlled model complexity, and we use judicious data augmentation. Obviously, if you try doing something like this, it will be full of limitations. As of now, there are a lot of limitations. That's why we are still just working on it and improving it every week. We are changing and adding more data so that the learning of the model is better. So the first important limitation is it is a single center data, where in our center it's almost HAV, which is almost 60%. So it limits generalization to other populations. We are yet to do prospective or external validation. In principle, 3 centers have agreed to do because it's just an observational study. So 3 centers have in principle agreed to do external validation for us. Relatively small sample size of 134 patients underwent plasma exchange and 110 were included, which is a small number for a ML model. I completely agree, but this number reflects the rarity of pediatric ALF. No other center has done maybe even 50 plasma exchange in pediatric acute liver failure. So this is the best that you can have, and on the other hand you have nothing. You are comparing with no way to predict the outcome. So we anticipate that as the sample set increases, the model performance will improve. Concomitant CRRT we believe can be a confounder. We have included CRRT into the model. which strengthens our real world applicability, because nowadays everyone who is using plasma exchange is using CRRT. So it strengthens the actual real world applicability by using the CRRT as a feature in the model, but the ammonia kinetics is very complicated and can be affected by CRRT in unknown ways which we cannot control for. We should have ideally done stratified ML models based on etiology stratification and CRRT use stratification, but that will again further limit our sample size and increase the risk of overfitting and model instability. Patients with ALF die of liver failure, but patients of ALF also die of sepsis. We have not been able to incorporate sepsis. We tried with Procal, we tried with cultures, but we have not been able to incorporate sepsis into the model till date. Another very important reason, the tool gives a risk of mortality. Now, so it says 35% risk of mortality. Do you consider if the patient is going to survive not for LT, or what do you consider? Someone may say that 25% is too high a risk of mortality and I should proceed with LT. So it just gives a risk of mortality, but it doesn't define what cutoff will be a response. This again becomes subjective at that time point. And there is a risk of overfitting with XG boost, which will always be there. So with these limitations, the future strategies would be to further train the model with increasing sample size, do the external plus prospective validation, and integrate the ML output when it is ready into real-time electronic hospital record systems. So to summarize, currently the prognostic modeling in ALF patients receiving TP is very arbitrary and completely subjective. Our model introduces objectivity, helps in early prediction of response to plasma exchange, and timely decisions for liver transplant based on SVM, XGBoost, and LR, which are the best models. We should standardize the biochemistry testing protocol, which should ideally be done 12 to 18 hours after each plasma exchange sessions. However, this model should only be considered as a preliminary framework, which requires refinement through larger data sets and external validation, and till then can be only used in clinical studies. Thank you.